Ladies and gentlemen, hi, good afternoon. I am Dr. Nicole Lawrence, and I am a geriatrician and an internal medicine physician down in Torrance, so just down the hill here a little ways. We have a concierge practice, which I can describe at some point, or there's some information in there for you. And today I am here to talk to you about falls, which is an issue I feel is of utmost importance, and clearly you all do too because you're here today. And I hope that I give you some useful information. Obviously we can't go through everything in a 30 to hour long talk, but I will also be available for questions, and we'll do what we can. Okay, so without further ado, this is a fall prevention talk. We're going to talk about the risk factors for falls. We're going to talk about the facts about them, and really then what you can do about it. So, flexibility I have on here is important. And I feel really passionately about this issue, and I'm going to be reiterating it. To prevent falls, you really need to be flexible. You want to remain independent. You want to remain, without, being dependent on others. Almost everyone tells me that. But what I want to emphasize to you is it doesn't just happen by magic. You can't just want something and then hope for the best. You have to be flexible and you have to be dedicated to it. So you have to be flexible in your mind, in your body, within your home. You have to be open to changes, and within your lifestyle. You really have to be open to some suggestions and changes. So I'm just going to start by setting the stage there. Okay, falls, are they really a problem? Well, yes. So 1 in 3 seniors will fall each year. So you can, if you want to raise your hand, I can say how many of you have fallen this year. You can raise your hand. Okay, so in this room, more than 1 in 3. But you are not alone. This is incredibly common. Okay, once you've had one fall, you have a greater chance of having another fall. There's a number of reasons why that is. One is often after you have your fall, you don't go further to pursue, why did that happen? What can I do to change it? A lot of people just sort of sweep it under the rug. The second reason is you've got to talk about why you fell so that you can kind of reverse those reasons why, or look at, what can I do to change this in the future? And then the next is we tend to get a fear of falling after we've fallen once. And then that sort of becomes a self-fulfilling prophecy, which we'll go through. Okay. The thing why we hate falls is it's not just because, you injure yourself and then you heal and that's it. But it's because it's a sense of loss of independence. Your quality of life decreases. You're more likely to be hospitalized. And then nursing home placement, where you can no longer care for yourself. When we talk about injury-related death, so most people it's car accidents. But for seniors, it's falls. So think about that. For those that are 65 and older, the number one cause of death with an injury is a fall. And it's a sobering thing to think about, that death is a possibility. And in fact, if your fall is so tremendous that you require hospitalizations for it, 50% will be dead within a year. And I can tell you in my practice that's true too. It's very, depending on the reasons you fell, but if you end up in the hospital because of the fall, there is a major injury there, and so, your risk is tremendous. So we all know that that's a serious issue. That's why you're here. So where do people fall? Mostly it's in the home. So 60% of patients fall in the home. I bring this up because a lot of people, I say, well, are you using your walker? Well, not when I'm at home. When I'm at home, I'm just grabbing on to this, that, or the other thing. I don't need it when I'm at home. Well, the truth is you do. Home is where most falls happen. However, 30% do happen in public places. And that's because there's cracks in the sidewalk, there's uneven ground, you're not used to the ground around you, and so you may not be expecting a change in, even this change right here, going from here to there. That's for some people that can be too much of a change, and you're more likely to fall. And then 10% will happen in a healthcare facility. So about 1 in 10 falls happen while you're in the hospital or if you're in a nursing home. So that is also something that happens. So why, how do we balance? It's actually an incredibly complicated mechanism, balances. It's not one thing. So the first is your vision. So you actually use your eyes in a very significant way to figure out how to balance and where you are in space. So, and it even becomes more important as you age because other senses, like your sense of where you are in space, decrease. So I'll give you an example. So when I'm standing here, I'm using my vision to kind of see where I am. If I close my eyes and I lift my leg, I feel very unsteady because my eyes are not able to kind of tell me where I am. And as you age, your vision becomes worse. Your inner ear is important. I already had a patient come up to me today and say they have some dizziness and that leads to the falling. So your inner ear has little rocks in it. We call them otoliths. And those rocks can become kind of unsteady and get dislodged. And that leads to a very difficult ability to see where you are in space. We call that proprioception. It really is the sixth sense. It's how do I know when I close my eyes that my hand is over here? It's your proprioception. So it really is the sixth sense. And when you have inner ear problems, that decreases your proprioceptive sensing, like I was saying. And then your strength and your flexibility. So as you age, you become a little bit stiffer and you lose some muscle mass. Those are things that happen. And so you really have to work to counteract those things. And the other thing is maybe your vision's bad, maybe you have inner ear problems, maybe you can't tell where you are in space, but if you're weak, then any one thing is going to cause you to fall, if that makes sense. So it's in a certain patient, if they have strong muscles in their belly and they have strong muscles in their arms and their legs, even if the other things aren't working, they can at least catch themselves in space. Okay, so why do seniors fall more? So we have a couple of ways that we think about it. There's intrinsic factors. So there's factors about you as a person. And then there's extrinsic factors. There's things about the environment that makes people fall more as they age. And then I like to break it down into what can I change and what can't I change, or modifiable and non-modifiable. You cannot change that you are aging. Every year you're growing older. But there are things that you can change. So focusing on the things that you can change is very important. Okay, so there's 4 categories we're going to go through about why people fall: biologic, medical, behavior, and environment. So let's start. So biologic. So as you age, no matter who you are, how fit you are, you have muscle atrophy. And what happens is that you start getting infiltration of fat into your muscles as opposed to muscle cells themselves. This leads to weakness. This causes walking problems. And then you become weaker, essentially. These are things that you can't necessarily change but can modify by doing more exercise. And we'll go through what exercises you need to be doing. Okay? The next is behavior problems. Again, this is something you can modify. So inappropriate footwear. So I am not wearing appropriate footwear today for fall prevention. I'm in a heel, it's a little unsteady, I closed my eyes and I almost fell. So you really need to have the right, is this just like, I'm not, but I'm still unsteady on my feet sometimes. So you need to have appropriate footwear. So one of the reasons that people fall is they won't wear the appropriate footwear because it doesn't look good. The next thing is refusal to use assistive devices. I could count, if I could count the amount of times a senior told me, I don't want to use a walker, I don't want to use a cane. I would be a very rich woman. But the thing about it is, you have got to set aside your pride. This is your life, and it doesn't matter how you look if you're dead. You need, if someone says use a walker, if someone says you need to use a cane, don't argue with it and do it. I can't emphasize that enough. You don't look silly. You look smart. You look reasonable. Okay, then lack of exercise. One of the most important things to do to really prevent falls is exercise. And it is so hard to get people to exercise. So hard. So I can't emphasize enough how important it is. The living in fear. So for a lot of seniors, they're so afraid about falling that it becomes a bigger and bigger issue. And we'll go over a little bit about that. And then next is cognitive impairment. So one of the biggest risk factors for falling is a lack of judgment. So if you have advanced dementia, it becomes very difficult to understand your own limits. So you think, okay, I'm fine, I'm just gonna get up. And you forget that you have muscle weakness and you can't find where you are in space and you don't have that memory. So that's one of the biggest problems with falling is if you have cognitive impairment. Okay, so there's also the environment. So poor building design, slippery floors and stairs, loose rugs, lighting is bad, there's uneven sidewalks, you can have clutter throughout your house. I put lighting on, poor lighting. If you don't have the appropriate handrails in the place that you need to be, this is like keeps moving forward without me touching it. And then items can be hard for you to reach. So something's on the ground, you drop something on the ground, you decide you're gonna go get it, and then you fall forward. So, and then having obstacles in your path, so you come across something that shouldn't be there. So those are all things in the environment that lead to the falls. And then medical is really the last category and a really important one. So multiple medications increase your risk of falling, either on their own or in combination because of the way that they affect your muscles and your brain. The use of medications that act on your central nervous system are one of the leading causes of falls. So sedatives or hypnotics, benzodiazepines. You can see on this list, I'll go through it in a second. The other thing is the vision impairment. So when you can't see because of glaucoma, because of cataracts, because of macular degeneration, it is incredibly difficult to walk appropriately because you can't see. You look down and things look closer than they are, or you can't see the obstacles in your way, so that's another problem. And then multiple disease states. I made this list not because we're gonna go through each of them, but for you to understand that the list of medications and the list of diseases that lead to falls are just gigantic. And so each of these things increase your risk of falling. To go through a few of them, when you have osteoarthritis, which I'm sure many of you have, the pain makes it harder for you to walk and more likely to fall. This thing is like possessed, okay? So, and then if you have osteoporosis, when you fall, you're more likely to injure yourself. If you have strokes, you're not able to move your body in the appropriate manner. If you have diabetes, you lose your sense of where you are in space in your feet. So there are many, many diseases that when layered on top of each other lead to your risk of falling. And then you add the medicines in as well. Okay, and these risk factors are interactive. So if you had one of these risk factors on your own, you'd probably be fine. So if you had great vision, you didn't have a lot of medical problems, you only took one medication, and you came across an obstacle on the ground, you could probably prevent yourself from falling. It just keeps moving forward. Okay, so if you, though, have 4 factors, you can't see, your muscles are weak, and you're on multiple medications, you're not going to be able to handle it and you're going to fall. So when you have more factors piled on top of factors, that's when the falling becomes more prominent. So here's the fear of falling that becomes a vicious cycle. So you're afraid of falling, so you won't do activities. Then you won't do activities, your muscles become weak, you can't balance, your gait becomes unstable, you're not able to function for yourself, so you feel like you can't do your transfers, you can't go to the bathroom by yourself, and then you fall. So it becomes a very vicious cycle, this fear of falling. So then you ask yourself, what can I do? So we talked about all the things that lead to falls. What can you do? Well, here's 2 people. The first one says, if I tell anyone I've fallen, I'll lose my independence. And the second person says, don't worry, I fell too. But after my fall, I took some steps. I had a checkup to make sure I was well. Some of the medications required changing. I was given advice on how to make my home safer. And I was given information about suitable exercises. So it's sort of like when you have the fall, we call it a sentinel event. It's an event in your life in which you remark, I fell and I am freaked out. You make a decision. Am I just going to do nothing or am I going to do something? Okay, so the first one is minimizing your medications. It's really important, and I do this with my patients. We review all the medications at every visit to make sure there is nothing on there that is not needed, because the more medications you have, the more likely you are to fall. And there are specific medications, like I said, like sleeping pills, some antidepressants. If you don't need them, you shouldn't be on them. Blood pressure medications that all increase your risk of falling. And so that needs to be reviewed very thoroughly. Okay? Optimizing medical conditions. So if you have high blood pressure, if you have diabetes, if you have heart disease, those all, increase your risk of falling. I work very hard with my patients to try to optimize those, make sure that they have the appropriate treatment for them so that it does not contribute to their risk of falling. Treat vision impairment. So older adults, as you may have all experienced yourselves, have decreased night vision, an altered depth perception, a decline in the peripheral vision. You get cataracts, macular degeneration, glaucoma, glare intolerance. All of this happens as you age. These need to be addressed either individually or together by your physician or an ophthalmologist if indicated. Because if you can correct some of the vision issues, you're going to increase, your ability to balance yourself. So that's very important. The appropriate footwear that we talked about needs to be fitting well, non-slip, a low heel, large contact surface area, and no slippers. So I often see patients in with flimsy slippers because they're comfy, but they are unstable and they lead to falls. And again, here's a step where a time where you really need to set aside your pride. You want to wear cute shoes. Well, you don't want to fall, and you got to think about what's more important. So you need to pick a shoe that is sturdy. Good shoes take you good places. Okay, physical and occupational therapy are very important. In the appropriate patient after a fall, I refer for comprehensive evaluation and rehabilitation of the impaired gait, balance, and working on transfer skills so you can be safe. The physical and occupational therapist will also evaluate for appropriate assistive devices, and they can do a home safety evaluation. So they will come into the home and they will do assessment, and sometimes I do this myself, if needed, where you go and you look and say, you need a grab bar here. You need, a shower chair here, and they'll kind of say, you need to take this rug up here. So they will look at your home in an objective manner and give you real ideas about how you can reduce your risk of fall. Okay, so addressing the home fall hazards. So clear the walkways of any cords, hoses, throw rugs, pets, clutter. Increase your lighting. It is one of the single easiest things you can do, but make sure your lights are really bright so you can see any possible hazard. Add rails to stairways, so make sure everywhere there needs to be a rail, there is one. You need porch railings too. Nobody should be going downstairs without railings. Not anyone. Not me, not you, not anyone. Use a railing. Clean wet floors. So making sure that floors are an even surface and that there's not anything wet and slippery is important. Next, bathroom safety. So many falls happen in the bathroom. So what can you do? You need to have grab bars around the tub and the toilet. You need to have a raised toilet seat if necessary, okay? So that you're just kind of grabbing. No one should be lunging forward from the toilet because you'll fall on your head and you hurt yourself. You need to work on strength here and also having the raised toilet seat. A shower or a tub chair can be incredibly helpful because you can feel safer in the shower. You're not worried about falling. A flexible hose is also important. So if you think about it, you have your shower chair and you have your hose, you really don't have to go anywhere. You can just bathe yourself and it reduces your risk of falling. A non-skid mat in the tub is important because the tubs are water and then they are a smooth surface, they're high risk for falling. Assisted devices is the next thing. So tools to help you. So you can get special step stools that are stable, a portable seat lift so that you have that with you, canes, walkers, reachers. So this is a reacher down here. So that's when I was talking about how if you can't reach something, don't start climbing up on the cupboard, get a reacher to help you. There are an innumerable amount of assisted devices which are appropriate for a lot of people, not for others. That's why it's important to get a professional assessment. Okay, so this is my, again, lecture on setting aside your pride. Walkers improve balance, they reduce weight bearing, which helps with patients who have arthritis, and they provide a four-way of stability. Canes can improve balance and provide support on one side of the body, but one thing they do is, as you age, it's more difficult to feel where your feet are in space, but your hand remains pretty much okay. So the cane helps by almost acting like another foot. So it's like you can pound the cane on the ground to know where you are. So canes can be a good way if you feel like I don't know where my feet are. Well, you can use the cane to help you get that, okay? But these should be fit professionally. So when you get your cane or you get your walker, you need to bring it into your doctor or physical therapist or occupational therapist, and they need to make sure that you're using it appropriately, because an inappropriately used walker or cane is going to lead to more falls rather than preventing them. But I'm really serious when I say, if someone tells you you should use a walker, you should use a cane, you should listen to them. Okay, so exercise. This is the best thing you can do for yourself. I say this over and over to my patients. It is the hardest thing, but it is the most important thing that you can do. There's 4 types. There's endurance, strength, balance, and flexibility. So, endurance exercises are really the things you're probably used to hearing about. Brisk walking, doing yard work, dancing, swimming, something that really gets your heart rate up. But that is not the end-all be-all. There are other aspects of exercise that are important, and I would argue that these other three types are the most important in reducing your risk of fall. So strength exercises are really aimed at getting your major muscle groups stronger. So lifting weights, using a resistance band. Have you guys seen a resistance band before? Okay. Using your own body weight. You don't need a gym. You don't need anything fancy. You can use your own body weight as a way to build strength. So for your arms, for example, you can go against a wall and push yourself up and down, okay? For your legs, doing bends and up, bends and up. You're really practicing getting out of a chair. If you're needing to use arms to get out of a chair, you're weak. That means that these muscles are weak. So you got to practice giving yourself a hug and standing up. Sitting down, standing up. These muscles are so important to preventing you from falling. Okay, balance exercises. So you need to stand on one foot, like I am. So it's hard for me, I'm even on heels. And what you'll notice is multiple muscle groups are activating when you do this. My core is activating, my hamstrings, my glutes, it's all being activated. And so I can do this for 20 seconds and then switch sides, okay? The other thing is practicing walking heel to toe. So that means you kind of put your heel and your toe, heel, toe, to try to create that balance. And then there's Tai Chi. So a lot of our community senior centers offer Tai Chi. And Tai Chi is a balancing exercise that has been shown in studies to reduce the risk of falling for seniors. So there's evidence behind it. Okay, flexibility. This is my favorite. So what you can do is really stretch your major muscle groups. So your arms, and you do 10 to 15 seconds per group, okay? And the reason is your tendons, which connect your muscles to your bones, stiffen as you age. And that lack of flexibility makes you more likely to fall. So you've really got to focus on stretching those tendons. So you, again, pick your major muscle groups and stretch. Okay, how much of it do you need to do? So endurance is 30 minutes, 5 days a week. Strength is 2 times per week. You do 10 exercises on the major muscle groups, 10 to 15 repetitions. Balance is 20 minutes, 3 times a week. And then flexibility, at least twice a week, but I think you can do more. So if you really want to reduce your risk of falling, I would say focus on the strength, balance, and flexibility parts of the exercise regimen. Okay, so what we do at our practice when a patient falls and they come in, the first thing is I assess their chronic conditions. You know, what medical problems do they have that could have led to this? I check their vision and their hearing. Then I am going to encourage good exercise, as I went through with you, as well as appropriate nutrition. This means you need to be eating and drinking plenty of fluid, because one of the reasons people fall is they get lightheaded or they get dizzy, and it's because they haven't been eating appropriately or drinking enough fluids. Next, we do osteoporosis screening. So one of the major problems with falls is that it creates fractures. Fractures lead to hospitalization. Hospitalization leads to nursing home placement and ultimately death. And so we're screening for osteoporosis and treating it. We're also doing a thorough medication review. Is there anything that we can reduce? And then for the seniors that need it, we refer to the physical therapist or the occupational therapist. So when a patient falls, it's really a multifactorial, multiple factors that we have to look at. So I just put this in, a visual. But it basically says the same thing, is there are a lot of things that you need to look at after you've had a fall. So at Sky Park, we're a concierge, like I said. We do primary care through the concierge model and geriatric care. We are available 24 hours a day, 7 days a week, via telephone, text, or email. So if something comes up at 2 in the morning on a Saturday, you can call us and we are there for you. We don't have any long waits in the waiting room or exam room. We really focus on prevention, not just of falls, but multiple diseases, and we don't just work on treatment. What concierge medicine is it's a direct financial relationship between the patient and the physician. So the patient pays an annual fee, and then in exchange, we're able to really provide this and enhance care. So when you think about traditional medicine, which you guys are probably all familiar with, it sort of goes like disease, treatment, and then cure. So you have one disease like high blood pressure, there's a treatment, and then you're considered cured. But what ends up happening is a lot of people who have many specialists and go here and there, or they have a primary care doctor who's not a geriatrician, they end up getting multiple treatments, multiple disease, multi-cures. It kind of goes on top of each other, and it leads to this too many medications, too many doctors, very little coordination, and overall a decreased quality of life and increased falls, to be honest. So we try to make you our priority by looking at all aspects of who you are. And this is my family. It's my husband and my son. He is now 14 months old. This is when he was born, and then when he was 6 months old. One thing I didn't mention, but I thought of as I was here and looking, some of you have the strings around your neck, the safety alerts. I highly recommend those. And not only do I recommend them, I recommend you wear them. A lot of patients have them and they're sitting somewhere else and then they fall and there's nothing they can do. They lay there for hours. So those safety device programs are really important, especially if you live alone. Because if you don't have access, you could lay there for hours or longer, injured. And I've seen it. So if you have one, wear it. If you don't have one and you live alone and you're worried about falling, please consider getting one. Okay, so I think that is what I had to say, and I would love to take your questions if you have any. Yeah?
I'd like to talk about statins. I've been on statins for years, as my wife. I got a reaction to them where it just made me feel I had no energy.
Yeah.
So I quit taking them, and I'm okay again.
Yeah.
She has that, and also the ability to walk is decreased when she takes them. Is this common?
Yeah, so it's actually less common than people may think, but it's definitely possible. So what I say about statins is they are not evil. They are the right medication for many patients, but they're not the right medication for every patient. And when you're making a decision about whether or not you should be on your statin, you're really considering, one, your quality of life. For you, it made you so weak you couldn't take it, and so you're off of it and now you're okay. For somebody else who has, advanced heart disease and has had strokes or is afraid of, having strokes, they would say, you know what, I just need to be on the medication. Maybe I need to try a different statin. So it's going to depend on the patient. But I would say, yes, statins can cause weakness in a select group of patients. And as you age, if you don't have any other risk factors, it becomes much less important that you be on the statin. But if you've had strokes, if you've had a heart attack, I wouldn't just go off of it for no reason. There should be a good reason why. Thank you.
Thank you.
Yeah.
To that point, and you just said as you age, there's less of a reason to stay on it?
Yeah, because if you think about it, you're taking a statin to reduce your risk of heart attack and stroke over a period of time. So if I take a statin today, I'm not going to see the benefit of it for 2 years probably. So if your life expectancy is 6 months, the benefit of the medication isn't there. Does that make sense? So it's got to be, it's not like I take it today and it saves me tomorrow. It's a cumulative effect. So that's why as you age, tight blood pressure control, tight blood glucose control become less important because the treatment becomes more harmful than the actual benefit because your life expectancy is decreasing just because you're aging. Yeah. Yeah.
For osteoporosis, are there newer medication other than those?
Yeah, there are. So there's a couple of two new medications that we use a lot. Prolia is the name of it.
Yeah.
And the other one is teriparatide or Forteo. So those are two different medications other than the bisphosphonates like Fosamax
Yeah.
that I use for my patients who have continued osteoporosis despite being on the Fosamax or whatever, or if they have indications in which they can't take the bisphosphonates.
Yeah. So is it a cure or just how does it work?
You know, you bring up a really important point. The treatment for osteoporosis is imperfect in many ways. So first of all, the guidelines were created by the drug companies. So I always tell my patients that one of the most important things you have to keep in mind is the absolute difference or reduction in your risk of fracture is not that great. And the way that the drug companies have created the guidelines makes you feel like everybody needs to be on it. And it's not true. Do they cure osteoporosis? No. So there's two different ways that these studies are built. One is, does it increase your bone density? So if I take your bone density on this day and then I give you Fosamax for X amount of years, is your bone density better? Well, yeah, the answer is bone density is mostly better. But who cares if you're still having a fracture? So what they said is the National Institute of Health said, you've got to make your studies actually matter. You can't just say a number is better. You have to say that there's actually a reduced fracture rate. Not just my bone density went from, a really bad score to a really good score. It has to be, no, I am fracturing less. So when those studies came out, the improvement is not as great, to be honest, but it is still there. And for some of my patients who are fracturing their back all the time, they've had hip fracture on the right, and I'm just waiting for the left to break, they need therapy because anything is better than nothing. So it's a discussion you have with the patient, that I have with my patients.
So is it
Yeah.
Osteoporosis drugs is that they become toxic after 3 to 5 years.
Yeah, so on the bisphosphonates, no more than 5 years. So that's Fosamax, Boniva, that kind of thing. After that, you take a holiday for sure. So that's correct. Yes?
What about diet and osteoporosis? I drink 3 milks a day, but I was using fat-free milk. And then I got this terrible diagnosis of the worst rib osteoporosis that this doctor saw on his chest x-ray. So I said, that can't be possible. I drink milk. What is the situation?
Yeah, so no, I mean, nutrition is not, the bad bone density you have now is from years of, one, it's genetic, and two, it's the risk factor is being underweight or being a normal weight. So this is a point where obesity is actually beneficial. I'm serious. And the reason is, is because the actual stepping builds your bones. So if you have more weight, then you're going to create, so there you go. So right now, so you need adequate stores of calcium and adequate stores of vitamin D. A lot of people think about calcium but not vitamin D. I didn't mention this in the talk because it's not completely clear, but some people think vitamin D reduces the risk of falls whether or not you are deficient or not. Just taking a vitamin D supplement because it's a hormone and there's something about it in the muscles that helps you balance or whatever. I use it in my patients that are actually deficient just because, I swear one time you learn one thing, then 10 years later it's completely different. So what I would say is you need to get adequate calcium and you need to make sure your vitamin D level is good, but that does not prevent you. That is not at all enough to prevent osteoporosis, especially at this age. The cat's out of the bag. Nobody here is going to prevent it. If you have it, we just have to manage it. If you were a 30-year-old woman, I would say You need to make sure you're doing exercises that are, gonna be good for you and everything. But weight-bearing exercises are still good, but it's just not gonna be as effective. Yeah, especially in your ribs. I'm trying to think about how you can do weight-bearing on your ribs.
With osteopenia, is it advisable to take bisphosphonate?
I would say no.
No.
hmm
But if you do weight-bearing exercises and you get muscle-bound so bad 3 days later, how do you cope with something?
We need to make sure you're doing adequate stretching. If you're not doing adequate stretching, you've got to do adequate stretching and make sure you're drinking plenty of fluids. Fluids are very important with exercise.
You get that at physical therapy, they teach you.
They teach you just what to do. Yeah, it's really nice. Yes.
What are your thoughts on taking calcium supplements? Because I've heard if you have too much calcium, that's not good also.
Yeah.
And how do you know how much?
Yeah, it's true. It's true. So my recommendation is get your calcium from your food. And if you're not able to get it through your food, then you can take it as a supplement, but that is not as good as getting it through your food. Now, the newest study is that too much calcium does not actually lead to heart disease. But I am telling you, in 5 years, it'll probably be, the latest study says if you take, so I want you to follow your intuition on this, which is what I am doing, is get your calcium through your food. Just do it. Because then you don't have to worry about, is the supplement bad, is it not bad? Get it through your food. We're not meant to get nutrition through a pill. It's just not the way our body is meant. Our body is meant to get nutrition through food.
And how much vitamin D do you recommend?
It's going to depend. Yeah, it's going to depend. It's D3, that's the only. It's going to depend on what your level is. But at this point, we don't think there's any toxicity to high levels of vitamin D, but that there probably is. Too much of any good thing is not a good thing. So I would have it depend on your level.
And I was just told, because I asked if they would, they did the blood test, and I asked them to recheck the vitamin D, and they said, oh, we only do that once, because once it's set, it's set.
Yeah, so I recheck it, okay? So I recheck it, but it doesn't surprise me that they said no, because they think, so the thought is once it's low, I tell you to replete it, then it's fine. But I recheck it.
And how much should we take? How many milligrams?
Again, it's depending on your level. So if your level is 10, I'm going to recommend a higher dose. If your level is 25, it's going to be different. So I can't just tell you, take this amount, okay?
So it's based on the bone density test?
It's based on your level of vitamin D. So when you did a blood test, it tells you how much vitamin D, what your level is. Yeah. Okay, what else? Yeah.
At the moment, we have Medicare supplement insurance. With your concierge practice, one keeps that insurance?
Yeah, you keep that insurance. We take Medicare, and then Medicare automatically bills your supplement. Yep. Exactly.
What is the out-of-pocket expense?
So the concierge fee is age dependent, and for a senior, it's $2,400 per year.
And what do you get for that?
So you get a comprehensive physical, you get access to us all the time, so I'm available to my patients all day, every day, at night, whenever. If you ever need to be hospitalized, I take care of you in the hospital. You don't have a hospitalist ever again. If you go to the nursing home, we take care of you in the nursing home. If you become homebound, we take care of you in the home. And if you end up on hospice, we take care of you in the hospice. We stay with you. We keep a limited number of patients so that we can do it. And the way that we keep the limited number of patients is by having the fee.
If I can add to that, inside your folders on the right side, the second page should be this contracts and details. And that really is the gist of what you get for your money and how your insurance works and so forth. And the payment fee schedule is at the bottom.
And they go to Kaiser too? You go to Kaiser too?
No, so if you're in an HMO, we do not take HMO. So Medicare and Medicare supplement, that's fine. But if you choose the Medicare Advantage or the Medicare HMO, we do not work with HMOs. I mean, right? I mean,
We do have patients who do have HMOs, but they use their HMOs for emergencies, and they use us for the access, because they would rather have access than go to Kaiser and wait 2 hours because they have a cold, or, not get the full comprehensive exams that they get
How
with
does
us.
that work in the emergency room when you're?
we go to the emergency room.
Well, no, I know, but once you're in the emergency room, are you there on observation, or are you in there to?
With a Kaiser patient or with a regular patient?
Regular patient.
Yes, so first of all, nobody goes to the emergency room without me knowing. So unless you're actually dead, I like to get the phone call before 911 is called, because we like to try to mitigate whatever is going on. If you need to be admitted to the hospital, I like to try to do the direct admissions myself so the emergency room isn't needed. But let's say you need to go to the ER, which does happen. I will meet you at the ER or be in contact with the ER physician. If it's in the middle of the day and I'm seeing patients, I'll be there as soon as I can. Or if it's the middle of the night, then usually come in the morning. But whatever the case, we meet you in the ER to do the admission. Does that make sense?
Yes, it does, and my mother-in-law has fallen 3 times in the last 2 months. Serious
She needs some,
transplants.
yeah,
And she does wear
her life alert.
life alert, but her hands were pinned against her body, so she wasn't able to, well, she didn't have one then. My question is, she goes to Torrance Memorial Hospital. Now, they already have her information, so how does that work with you? I mean, we automatically bring her there via the ambulance, and then,
Right. So then I would take care of her in the hospital.
okay.
You
That-
call Dr. Lawrence.
You call me and you say, my mother-in-law is on her way to the hospital. She fell and can't get up. I say, okay, I'll see you there. And then I'm there.
But you do not become the treating physician.
I do.
Oh, you do?
I do, yeah. So there's no hospitalists. The ER physicians love it because they're like, oh, great, I don't have to do anything. Yeah, so we become the treating physician.
Okay, so then you work with the staff.
Yeah, the nurse, it's like we have admitting.
It's not observation because insurance will pay if it's under observation.
Yeah, if it meets inpatient criteria, it's inpatient. It's just, that's a complicated decision, but yes.
Yeah, she comes in by paramedic ambulance. She has a reason to be there.
Yeah. Yeah. Go ahead.
My friend is a member of POC, and he said that when he goes to the hospital or emergency, he says that the admittance is expedited.
Mm-hmm. Yeah, you
As
don't
being a
have to.
member.
Yeah, that's what I'm saying is, I basically just, we basically are there to make your lives easier. We don't want you sitting in the ER for hours. If you need to be in the hospital, we make it happen. Yeah. Yes.
Okay, PPO and so you have Medicare.
Yep.
And PPO. So is that covered by your Medicare and PPO?
Yeah.
Partially, when you go into the hospital.
Yeah, they cover. You keep your Medicare, you keep your PPO. There's nothing different. Everything that Medicare covers, they continue to cover it. The only additional cost to you is the concierge fee, which is not covered by Medicare. But your labs are covered by Medicare,
So everything, this is just like extra.
Exactly. But
Medicare covers now is going to cover the same as long as you're going to a Medicare participating provider, which we are.
So
The hospitals are providers, and the doctor that you go to will be a provider.
PPO and you have PPO and Medicare, no.
yeah, exactly. They'll continue to be your coverage. Yeah. Yes.
Well, my friend also goes, he gets like blood tests, blood work done quite
Yeah.
often through the year.
Yeah.
Every 3 or 4 months or something, and then, but like, I'm at Kaiser, and they're just giving it to me like once a year.
Right. So we try to keep a closer eye on our patients. So part of what our goal is to really make sure we catch issues before they come up. That makes sense. We don't want you to be sick in the hospital. That's why a lot of these things about being in the ER, we try to avoid that as much as we can. You know, if you need to be in the hospital, we'll make sure it happens. But if you need to be seen that day because you're having pain with urination, don't go to the urgent care. You never go to an urgent care again. You don't go to the ER. You come to our office. We see you that day. That's, you know, we try to keep everything as effective as we can to keep you out. Yeah. Any other question? Okay, fine. Yeah.
You make home visits?
Yes. Mm-hmm. Okay, yeah.
I'd just like to commend you. If you had been my husband's doctor, he would be alive today.
Oh, thank you. Yeah,
Because he was on statins, he developed pulmonary fibrosis. None of the wonderful doctors, many wonderful doctors we went to, knew that sometimes, rarely, but sometimes, you can get pulmonary fibrosis from statins. And if they had known that and taken him off there, it would have been a different story. And so I really was applauding you in my heart when I was saying, make sure that the medications are essential. They have my aunt and my mother were on 20-some medications. Ridiculous.
Yep.
Thank you.
Yeah, you're welcome. Thanks for coming. Thanks for those kind words.
So much for coming to our
You're
community.
so welcome.
Oh my gosh, you guys are
Happy to be here.
On behalf of Sunrise, we are just so grateful that there is someone like
I
Dr.
love you
Lawrence.
too. That's my patient.
So anyway, we hope that you can come and visit us many, many times.
Yeah, whenever you want
And
me back, I'll be
obviously
here.
it had a great response.
Yeah.
We had such a good attendance, so thank you all. Thank you all for the visitors. Thank you all for our residents for coming. We really appreciate it.
Yeah. Bye-bye. Yeah, thank you.
Yes.
That was my thanks for having me. Appreciate it.